Welcome to Osteoarthritis Treatment Lecture number 2. In this lecture, we'll be talking about therapeutic modalities for treatment of osteoarthritis. So, what are our therapeutic options when it comes to treating arthritis? As with any treatment, so the most successful therapy will require a combination of pharmacological and non-pharmacological approaches. So non-pharmacological approaches are always first line. Why? Because these are the safest, most uninvasive, and basically we start by encouraging patients to either reduce their weight or engage in physical therapy activity, start walking to strengthen their muscle, basically anything that can help to reduce the load or pressure on the joint and slow down the destruction of the cartilage or destruction of the joint. The pharmacological therapies, so these are meant to actually help reduce the symptoms that patients experience. And there's two different types of therapies. So the fast-acting therapies, these are meant to, alleviate pain and inflammation. And when we're looking at these therapies, these are our traditional go-to drugs for pain relief. So Tylenol, NSAIDs, glucocorticoids, opioids, and then slow-acting group of drugs. So these are more natural supplements and more holistic medications that are thought to actually help contribute to joint repair a little bit in some way. And these are going to be glucosamine, chondroitin, or hyaluronic acid. And then the endpoint therapy is going to be prosthetic joint replacement when all the other treatments have failed. So let's look at the fast-acting therapy. So the most common or number one or easiest fast-acting therapy is probably Tylenol. Why? Because Tylenol is amazing. Tylenol works really great. It's very effective at pain relief. It works fast. Side effects are minimal, and then doses below 3 grams a day are recommended and are fairly safe. Non-steroidal anti-inflammatory drugs. These are our go-to agents. We don't use them so much for inflammation and osteoarthritis, yet they're very good and they're effective at providing analgesia. So they're used very widely, but their use should really be limited to short term. Why? Because with chronic, long-term use, they have a potential to produce a wide variety of different side effects, renal effects on your kidney, cardiovascular side effects, GI adverse side effects, stomach discomfort, dyspepsia, even leading potentially to some ulcers. So if you're taking them orally and you're experiencing a lot of gastrointestinal side effects, one thing you can do is actually take a group of drugs known as proton pump inhibitors, and they can help you mitigate a little bit some of that GI discomfort that you're experiencing. Glucocorticoids are actually really effective in osteoarthritis, and what they're basically doing is they're great at preventing pain and helping reduce some of that inflammation that's in the joint. And these are basically injected intra-articularly directly into the joint. They do provide short-term relief, and there's a potential, just like with any steroid, for metabolic effects. So their use should really be limited to every 3 to 4 months, and depending on a schedule that the manufacturer recommends. And then opioids, these are sort of like a final step when the pain is not controlled by other therapies. So opioids are, they have a lot of side effects. We talked about them, especially when you think about all the CNS side effects that they have, and the patient population that we're looking at, older, elderly patients. These are people that are going to be frail, people that are going to be especially susceptible to CNS or mental status alterations. There's also potential for addiction and tolerance. At the same time, what you really need to think about when you think about opiates is that they are really effective at relieving pain. So there is definitely a clinical niche for them, and other therapies may not necessarily always fill that niche. Why? Because, for example, topical therapies, one of the reasons that there are limitations to their use is because there's a minimal systemic absorption, so there's a low potential for side effects. At the same time, with low minimal systemic absorption, since the drug is not distributed throughout your body, there's only so much that it can do because it's not distributed into the tissues. So opioids can be an answer, and opiates can be used clinically appropriately for treating pain and very severe pain. When we look at slow-acting therapies, the idea here is that we're trying to prevent pain and also deter the destruction of cartilage. If you notice, glucosamine, chondroitin, and SAM, acetyldenacylmethionine, are three go-to natural supplements that are traditionally thought of slow-acting therapies when you think about osteoarthritis. There's another one that I'll bring up later that you need to be aware of as well, but these three are really the key ones. So glucosamine is a natural supplement. It's actually derived from the shells of crustaceans, and what it's thought to do, it's thought to stimulate the synthesis of collagen. As one of its positive effects, the way that it therapeutically is thought to act in osteoarthritis is that it's thought to reduce the joint space narrowing. Remember, we talked about before how you have that joint space narrowing in the X-ray radiograph of the osteoarthritic knee. So glucosamine has a positive effect that's thought to mitigate that and reduce that joint space narrowing. But there's actually no demonstrated effects on preventing deferring erosions of the cartilage. So chondroitin is another natural supplement, and it's a component of the extracellular matrix. Orally, it's usually taken to slow down the activity of the enzymes that break down the cartilage. And remember, cartilage destruction is one of the key pathological processes that happen in osteoarthritis. Unfortunately, the GATE trial, which you should be familiar with the GATE trial is basically glucosamine chondroitin arthritis intervention trial, and this was a large randomized placebo-controlled trial that was conducted at several sites across the United States, and it was partially funded by the Arthritis and Musculoskeletal National Institute. So what this trial actually found was that chondroitin demonstrated no effect in reducing pain versus placebo. However, in a small subgroup of study participants, it did show some benefit. And lastly, acetyldenacylmethionine is basically a coenzyme, and the oral intake is thought to help reduce pain, and it potentially may help with the repair of the cartilage. So injectable steroids, these are for example, something like depomedrol, and this is a molecular structure of depomedrol. So these are injected directly into the knee every 3 to 4 months, and they help relieve pain and inflammation. They're very effective. Opiates. We talked about opiates. So opiates would be using something like hydrocodone and acetaminophen, or using OxyContin. So if you remember, what is a brand name of acetaminophen? It's Tylenol. So the combination of hydrocodone and Tylenol is what? There are a few brand names for it, but typically known as Vicodin, Norco, sometimes Lortab, depending on the strength of all of these. And then OxyContin is just the oxycodone, and there's control release, immediate release, but this is a brand name for it. So some of the topical therapies that we have that are commonly used in arthritis, and you can see some of these actually say arthritis pain relief on their packaging products. So we have capsaicin is very common. Capsaicin is usually used in strength of 0.025 to 0.075. So Zostrix and Capzacin are two commonly used products. Zostrix has actually a higher concentration of capsaicin at 0.075 versus Capzacin has 0.035%. Still, if you think back at what strength do we typically use at Mega 8 Pharmacy for the concentrations in our compounds, these are typically 0.025%, so the two of these are actually higher. And then Bengay, this is another topical pain medication, and this one contains a combination of menthol and camphor, which are two counter irritants, along with methyl salicylate. And methyl salicylate is basically a medication from the salicylate class of drugs. They're related to aspirin, and they're thought to provide topical analgesia as well. And then Icy Hot here is just another product. So the compounds that we have that target treatment of osteoarthritis basically contain a combination of nonsteroidal anti-inflammatory drug, for example, diclofenac, or ketoprofen, which is another nonsteroidal anti-inflammatory drug. And you can see that this one actually has two counter irritants, camphor and menthol, and these are thought to work. Basically what they do is the mechanism of action is within the name. They counter irritate the skin, so they produce this cooling effect on the skin, and in doing so they basically distract your brain from perceiving the pain that was originally perceiving and perceiving this sensation, so that alleviates the feeling of pain that you were initially experiencing. And then this one says for rheumatoid arthritis P210, but it's actually very ideal for osteoarthritis as well. So this one contains an NSAID, and then contains a glucosamine that we talked about that may help with the joint space narrowing. And then MSM right here. So MSM is another chemical that's found in plants, animals, and it's basically supplies your cells with sulfate groups, and it's involved in multiple different processes, but bottom line is thought to help relieve pain as well. And here's an article in New York Times where you can read more about these two natural supplements. Some of the other topical treatments are topical NSAIDs. This is what we use in our compounds, so you can see what your competitors are. So Pensaid is actually a diclofenac, and just like diclofenac here. And then Pensaid has a couple different formulations. This one's actually 2%, but there's also 1.5% available. Voltaren is just 1% diclofenac, and then Solarized gel. This one's not approved for treatment of pain. It's actually approved for treatment of actinic keratosis. So when it's used for pain, it's used off-label, and there are multiple problems with insurance coverage. But it's 3% diclofenac, and then Aspir cream is just another salicylate. And then there's a couple other topical therapies. For example, here's a combination. You can see this one's a combination of menthol, 10% higher, methyl salicylate, camphor, and then capsaicin. So this one has all four natural supplements. And then lastly, when all other therapies fail, you can basically resort to surgical treatment. So with all of these, bone is going to be removed, fused, or replaced. So something's happening to the bone. So osteotomy, it sounds like really benign and cuddly and fluffy, but it's actually a pretty big procedure. And what it does, it targets the misalignment in a joint. So bone is removed to cause realignment and to reduce the mechanical stress on the joint. But like with any surgery, there is a potential for nerve damage, adverse reactions, and bleeding. Arthrodesis is basically artificial induction of joint ossification. So you fuse one bone with another, but this is typically performed at smaller joints like wrist, hands, ankle, or feet, thought to provide pain relief. And finally, arthroplasty is basically total joint replacement, usually done in hip or knees, and this is a final resort when all the other therapies have failed. Now, this is a list of reference for you to look at if you want to learn a little bit more about treatment of osteoarthritis, or if you're interested in reading any of the articles that I use in putting together this presentation. Otherwise, thank you so much for your time.